Hello, everybody. This is the live case session. I am Hong from Severance Cardiovascular Hospital, and my co-moderator is Dr. Chen from China. We have several distinguished panelists, Dr. Wu, Dr. Do, Dr. Nakamura, Dr. Gogas, Dr. Lam. Actually, this session is a left main intervention session, and as you know, left main is the very interesting and the educational experience. As we know, the AMC is the pioneer in the left main intervention. There are two cases of the left main intervention. Dr. Bach?
All right, so great. Good to see you. All right.
We can clearly hear you. Please.
Okay. Can you hear? And first, I really would like to, thank you all for joining us and TCTAP 2021 for sure. Actually, very happy to have, our old friend, including Dr. Hong Chen, Shaoliang Chen, Dr. Do, Bill Gogas again, Dr. Lam and Dr. Nakamura and Dr. Wu. Really thank you for joining us. All right, for this live session, we actually prepared two cases of left main disease intervention. All right, so we want to start our first cases. So Dr. Kang and Dr. Chung-Jen, our family, Mr. Zhang and all the team really have lots of effort to preparing, these cases. Okay. All right. Please start, Dr. Okay. Dr. Lee, you want to do that?
Thanks for the opportunity to present this case. Our patient is a 70-year-old female patient who was referred from other department for effort angina. And her outside CT scan showed that severe stenosis at left main and proximal LAD. Next. She didn't have other apparent medical history. Next. On presentation, her ECG was normal. Next. Her echocardiography was also normal. Next. Right coronary angiogram showed mild stenosis, and left coronary angiogram in this PA coronal view, you can see that there's a significant stenosis at proximal LAD and distal left main. And also, we can appreciate that there is a lesion in the proximal circumflex, which angiographically looks significant. Next. And moving on to further projection, it is quite clear that proximal LAD is the culprit, and we also did FFR. Next. With full hyperemia beyond the target, the LAD FFR showed a stable value of 0.77, and there is a major step up across the proximal LAD. Next. However, the circumflex was 0.92. Okay, Professor?
Okay, great. Would you show us again the other view? This is aerial, shallow caudal. This is spider view. Clearly, angiographically, some narrowing on the circumflex osseous part. However, not too much significant. Functionally, 0.92 is clearly normal. And proximal, very proximal LAD, there are some, significant narrowing by even in the angiographic finding. Would you show us another view? Okay, great. If we look at this, it's the proximal to, part of a mid portion had some diffuse disease. And so patient actually 70-year female.
Yes, 70-year-old.
There are lots of comorbidity status, however, presented in its very unstable minimal effort to chest pain. No doubt about, patient had ischemia. All right, so Before the obvious findings, we almost routinely use the obvious guided procedure for the main intervention. So would you discuss, about how do we treat them, just only according to the angiographic findings? And what do you think is obvious guided, FFR guided concern?
Personally, I think the FFR is necessary for the evaluate the presence of the ischemia of each vessel. And the second one, if you decide to the intervention, the imaging is absolutely necessary for the have a plan to the what kind of the treatment strategy for the single stent or the two stent strategy.
Great. So, Shaoliang Chen, do you depend on others? All right.
Yeah, absolutely, Dr. Park. Thank you so much to invite me to join your work. So I think baseline FFR for RAD is very, very important. It means very significant ischemia from the osteo to the proximal part of RAD. So even there is some plaque from the angio, but the lesion in circumflex is non-significant ischemia. So at this time point, I think IVUS is much more important. Just one question, Dr. Park. How many percentage of IVUS guidance for left main disease in Asan Medical Center?
Almost all cases for the main intervention. All right.
Congratulations.
All right. So, all right, great. As we're going to discuss later in the how to treat concern, and so we have already done Armstrong from the LAD to circumflex, and so Dr. Kang, would you
Yes.
explain that one?
We already checked the IVUS from the circumflex and LAD, and let's check the LAD run first. Yeah, this is the IVUS from the mid LAD.
Great. Below the diagonal
Yeah,
branches?
below the diagonal branch. Let's share the IVUS with angiography, and this is the mid LAD at below the diagonal branch or septal branch. As you can see, the vessel is normal and mild disease, mild plaque from here. The vessel size is about 3.5, and very small amount of the plaque is seen below the diagonal branch. And here, just below the diagonal branch, there is a moderate amount of the plaque, but the lumen is preserved. And you can see the big diagonal branch is coming in from the 12 o'clock. And now here, the proximal LAD. I think that here proximal LAD, there is a relatively preserved zone at the septal branch, as you can see in the 6 o'clock side. And that could be another landing zone that can be considered. And if we move proximally, there is eccentric calcified plaque, you can see, and the lumen is becoming narrowed, more and more narrowing at the proximal LAD. Diffuse plaque would be the region of the can be region of the important angina and drop of the pressure during the FFR measurement. And here, very proximal LAD, you can see that the lumen is a little bit become larger here. And circumflex comes from the 10 o'clock side. And when in the LAD pullback, circumflex ostium looks widely opened. And distal left main, there was a tight stenosis. And shaft of the left main, there's only mild plaque. And near normal at the very proximal part of the left main shaft. And vessel size is large, more than 4.5. And this is the long LAD pullback. And we also check the circumflex run.
Okay, Rory, go ahead. All right,
Yeah.
circumflex, right?
This is circumflex run because there was some angiographic narrowing of the angiographic narrowing on the ostium. So we also wired into circumflex and checked the IVUS to evaluate the ostium of the circumflex. As you can see, there is a mild plaque, and here is the ostium. Let's see. Yeah, there is some mild plaque at the opposite side of the bifurcation.
Here,
Yeah.
ostium preserved.
Yeah.
The disease extend into the POC area, polygonal control, right?
Go ahead. Go ahead.
All right.
Yeah. Here is POC.
All right.
Yeah. And this is left main. LAD IVUS 다시 볼까요?
So would you show us LAD ostial part exact, ostial right here? All right, just before the circumflex takeover from 10 o'clock. Anyway, the lumen area is if we got some, imagination about outlines and maybe 3 something, 3 millimeter square. And very diffuse, significant plaque over there. So, all right. You have some idea about what the status in IVUS findings, ostial part of circumflex, ostial part of LED, and what do you think? How would you treat them?
You mean
Dr.
one
Kang
stent
first.
or one stent or two
Oh,
stent? You mean?
right.
As I have some concern of the circumflex ostium because there was some plaque, but I think it's not so tight, and the plaque location is on the opposite side, and circumflex size is not so good because this is RCA dominant patient, so I would prefer the crossover provisional stenting.
Great.
A question to the Professor Chen regarding the definition 2.
Too big.
This is a one stent strategy, or you still favoring 2 stent strategy, Professor Chen?
Yeah, based on definition criteria, angiographically, it could be classified as simple bifurcal lesion. So even the ostial circumflex looks like some plaque burden, but angiographically, the diameter stenosis looks like 50-60%. So I will go prominent stenting technique after stenting LAD left main. So probably we need to remeasure FFR or IVUS for circumflex. Once there is the severe compromise, I think we need to balloon insert casing, or even we can use drug-coating balloon, something like that.
And another question is to SJ Park, because in China we use a transradial a lot. Nowadays, right sheet slender, we can use 7 French routinely. So you're still using 8 French for the left main bifurcation. Is that your routine, or you consider maybe you can 7 French still okay? And transradial would be a future option, or you still like to do a femoral approach?
Great, issues. Actually, we used the 7 French guider.
Yes.
Right. It's a little bit. I've changed my mind. The reason why, even in the, for the safety concerns, I really prefer big surgeon like a big incision. All right. However, recently we do a kind of a stent cross, simultaneous 2 stent, not pretty many cases, right? Just to do the stent and balloon crochet and DK crochet, just initial sensor test, and then another stent over there, and balloon and stent. Sometimes we're going to use the 2, device. However, stent versus stent, as recently we reduced chance to use, and so we just choose a 7 French, right? Yeah. That's the answer. All right. What do you think, Dr. Who is over there?
Yeah. I accept that. Yeah, explanation.
Right.
Okay.
Right. Okay. So, as you suggest, as we're going to do the stent crossover. However, I was discussed with Dr. Kang about what of the 2 stent. How Dr. Kang, many moderators, the panelists maybe have some, resistance about that. However, look at that. I agree that provisional stent. The reason why there are some diseases ostial part of circumflex. However, in terms of branch angle, quite stiff, and so really even after main branch stenting, there is more chance to preserve the circumflex ostium. However, if there are not too much disease, very small disease, however, angle is shallow, then maybe compromise, and even after main branch single stent crossover. And so, in my thought, even functionally is 0.9 something negative FFR. However, technically we cannot preserve the circumflex ostial part. I prefer recently anyway upfront to stent. Why not? You're gonna do that. First one, at first it's big artery, circumflex. Actually, it's 3 or more than 3.5, something big artery, minimal plaque over there, and combined two stent can make any stent technique can make a big effective stent areas after the two, even after the whatever the two stent technique. So in honest, is for the long term clinical outcome, two stent may be more safer than the provisional T-stent, and it's more simpler to make a immediate after good clinical outcomes. And so, however, in particular, this case is a minimal plaque ostium circumflex and angulation is very steep. So I believe stent crossover is quite good. I believe that. And another issues. What do you think? Would you show us the first view?
Yes.
Ariel. All right. Aaron. All right. The stent placement in the distal part. What do you think? Is it after the diagonal branches or before the diagonal branches? You want to make a 10 millimeters stent length. We measure the by August. If we deploy the stent below the diagonal branches, maybe 48 millimeter long, single long stent is quite enough. And if we decide the stent placement in the just above the diagonal branches, 38 millimeters, stent would be okay. Yeah. So, what do you think, Dr. Hong, Myeong-Ki Hong?
Okay,
You got some data about that.
Actually, is the technical aspect and the IBS finding. The IBS finding is that the LAD RCM is quite tight, and the RCM of the circ is relatively preserved. So based on this finding, the provisional stenting technique is more better than the two-stent technique. However, technical aspect, the hyperacute, the circumflex. So when we deploy the stent from the crossover the circumstent, that case is because of the hyperacute angle. Therefore, there is a chance of the compromise of the circumflex. That is just the anatomical limitation. So, how do we overcome this kind of limitation? It depends on the experience. If the beginner's level is if you prophylactically two-stent is a maybe, but the level of you just show us just the crossover because you have a lot of the experience of that. So it depends on the operator size, and another interesting finding is that there is a size discrepancy for the mid LAD and the left main. In the mid LAD level, the vessel size was about 3.3 or 3.5, and the left main is 4.5. So it depends on your decision. If you want to fix it just a one long stent, maybe from the distal main to the LAD. But you want to fix it the more distal, more mid LAD, you can fix it two stent. So it's up to your decision.
So, focus, Dr. Hong, is do you want to, distal stent placement on the just above the diagonal branch or just the distal part of the diagonal branch? That's
For me, I will deploy the two stent. It's 3.5 and the mid LAD.
Two stent from the distal part of a diagonal branch, right?
Yes, beyond the diagonal branch.
Okay, great. Any suggestion, Bill? Gogas, Dr. Gogas?
One of the questions regarding the lesion repair.
I agree with Dr. Hong. I go with the stent overlap. Yeah, I agree with Dr. Hong. I was saying that stent overlap might be better here. Distal to the diagonal, a 3.5 stent to the LAD, and then a 3.75 or more proximal to cover the left main.
What do you think?
And I also have a question, Professor Park.
All right. I got idea.
Yes, Dr. Gogas, please go ahead.
All right. If we choose the...
Yeah, so Professor Park, when you
We cannot hear you, Dr. Gogas. Please, can you speak again? Yeah.
Technical.
can you hear me? Can you hear me?
All right,
we can hear
now
you.
we can hear
Yeah,
you.
we can hear you.
Yeah. So my question is, when there is disagreement.
Agreement for two-stand once again.
So when there is disagreement between physiology and imaging, for example, if you find
Discrepancy between FFR and
Our
IVUS
connection
finding
is
him means I think.
Right. I functionally, whether the presence of ischemia concern is absolutely, I believe, FFR, right? However, just Dr. Hong mentioned about, technical issues, even circumflex is negative FFR. However, we know that is even after the main branch stenting is a large of degree, compromised circumflex ostium depending on a disease status, depending on angles, LAD and circumflex. And so, what I'm talking is even negative FFR functionally. However, technically, we're going to expect some, complicated provisional T's. Sometimes it takes time, and for those expectations, I would like to upfront to two-stand, right? To save the, times, and also I would, got some idea more safer procedure, simple procedure. I think two-stand is more simpler procedure. I think so, right? All right. So,
Dr. Park,
yeah.
I have a suggestion. I think just as Shaoliang said, it's a simple bifurcation, but you also have the concern of the circumflex compromise. My suggestion is use the gelled balloon technique. And when you put stand from LAD to left main, put a balloon at the circumflex, and you have the chance to avoid implanting and stenting circumflex.
Right. Great idea. So, how just place the balloon, you mean? Just place the
balloon technique.
All right. In case of compare with the two cases. Just leave it alone. All right. So main stent crossover 80% compromise for functionally negative, and for those cases, you're going to do the balloon inflations for the morphology corrections, uncomfortable situations. However, I don't believe the balloon inflation may have some balloon injury to the vessel walls, including any plaque over there. If you do balloon inflation for those reasons, I think it's a reactive hyperplasia or something like later, restenosis rate maybe a little bit higher. We have some data, very small numbers. If you do some damage to the vessel, look like a normal looking vessel, a little bit higher TLR rate on. However, hard endpoint concerns the frequency of MI death is no difference at all. So, to be honest, I don't touch. In fact, visually, tighter stenosis. Okay, you're gonna see that what's happened, right? How much it compromise the circumflex. You can do, right? We discuss. So, what does size-wise? Dr. Hong suggests the two-stand, and the reason why. However, Sierra, if we choose the Sierra 35, we're gonna do the maximize stand diameter up to 4.5. All right. So we actually prefer if there are some size discrepancy, distal part of proximal part, the Giants recent stand actually compromise from the 3 and 4.5, 3.5 up to 5 or something like that, right?
Yeah.
So we choose I would like to cover distal part of diagonal branch. The diagonal branch ostial part is absolutely normal, so we don't need any wire protection, something like that. I don't want to do that, and just do, long stand. Okay, why not? Do 40. And so we choose the 48, 35?
Yeah.
All right, that is ready? Okay,
48.
Yeah, 48.
48. So what I asked is Dr. Hong got some data. 38, 48. Is there any difference in terms of
longer than 40 millimeter stents.
Right? Myeong-Ki Hong, what do you think?
I think it's maybe similar.
Maybe similar.
I think the longer the stent length, the higher.
Absolutely. I think we don't have any difference. The reason why the placement of a distal part and distal part of LAD actually not too much plaque over there, and so even we deploy the stent, the reactive, some response is very minimal, test risk, and so I don't believe too much difference in terms of 38, 48. Okay, please.
So SJ, this is a primary stenting without pre-dilatation, right?
Oh, right. We have not enough time, so I want to show too much talk, right? Some short. Test, please. All right, too much talk. Test, please.
Test.
And ostial part of main, however, mid portion of shaft is covered. And distal, again, test. Distal downward branch is covered, right?
Yep.
All right, inflate.
So what's the stent diameter? It's 2.5?
3.5.
Yeah, 3.5.
3.5 force, and then we're gonna, do high pressure, non-compliant balloon inflation sequentially from the mid portion of LAD to the main area, right? Actually, the delivery balloon itself is semi-compliant, right? And so we're gonna do a little bit high pressure, pull the out of the balloon. And why not? 18,
16,
20,
18.
Okay, what is final diameters? 3.8.
Yep.
That is
3.8.
Yeah, major diameter of stent. Okay, deflate.
Deflate.
We have to wait. All right, to totally deflate the balloon. I don't want to make some damage. Bladed balloons. The meaning is uninflated balloons, right? So, all right. So, angiography confirm for downward branch is perfect.
Yeah.
And so I want to just show what happened, circumflex part. And then we're gonna. Okay, it's more clear. No. Okay, take a picture, full shot. Oh.
Okay.
All right.
Excellent.
Very much. It's more than 80.
Yeah.
More than 80. I prefer 2 stents for that as well. All right. We're gonna limit it. However, if we want to do FFR, actually I prepared, expected. What do you think? Negative FFR. 0.8, 0.82 something, right? Anyway, very discrete narrowing, not too much flat. So, to be honest, we're gonna do high pressure inflation for that.
Yeah.
After that, maybe the degree of compromise a little bit changes, and then we're gonna decide the FFR. We're gonna do that. And so before that, anyways, you show the obvious finding first, and then we're gonna move to second case.
Actually, at this time, we need the wiring to the circ, and
right.
then
Okay.
we will, and then the high pressure.
As you gonna move out the wire further from the circumflex?
No, I will use the third wire.
Third wire.
Yes, third wire into the circ.
Okay.
Maybe there is some chance of more compromise of the circum during the high pressure.
All right,
in
great.
the left main and the proximal LAD.
Great
As you
idea.
know, the stent size is up to 3.8. Actually, left main is 4.5. So we need a more high pressure in the proximal LAD and the left main.
Great. So,
At
okay.
this time point, Dr. Park, I suggest because I was on site, so I prefer to check IOS before post-dilation. Dr. Hong is very experienced, for just left main bifocal lesion. If the compromise of osteocellular is induced by coronary shift, it will be very safe to do post-dilation of RAD left main stent. Otherwise, if it's caused by plug shift, so before post-dilation, I will prefer to rewire stent flap. So I think IVUS right now is very important.
So, all right, so we have limited time, and so we're going to move to the second cases, and we're going to show final result as you saw there, stains on the wire for that and high pressure, and we're going to show what's happened, right?
Okay, great.
Okay, great. So we will move to the.
Hello, can you hear me?
Yes, DW Bob.
Yes.
We can clearly.
Okay, thank you. Thank you for joining. Okay.
Please introduce your cases.
Okay, thank you. Thank you for joining the TCT 2021, the virtual live case demonstration meeting, and appreciate Professor M.K. Hong and the Shaoliang Chen, our friend Kefei Duo and Bill and Horam, and the Dr. Sunao Nakamura and Chen Chiung-Jen. And so, our second case is a much complex case than first case. We're gonna introduce our team. The Tae-ho Kim is our senior fellow, Arang Kim, and she is our junior fellow. Okay, Dr. Kim, can you introduce patient background?
Yes, let me introduce this case. I'm Dr. Kim. This patient is a 76 years old male. He received the PCI for left main bifurcation region 1 year ago. During the follow-up, he complained of epoch chest pain and myocardial perfusion defect was found on the Salim spec. The previous PCI was done using the drug-eluting stent. Next. He has the
previous one. Could you at 1 year ago, she received the left main the crush stenting. Suck is put the two long stent design 3.028, distal part 2.7523, and the left main part is left main crossover design 3.528. Mid distal RAD is a 3.028. Okay.
Yes. Next. He has the hypertension and hyperlipidemia. His clinical presentation is stable angina about CCS class 3. Next. His electrocardiogram showed the basically normal sinus rhythm without the STT change. And next, his chest radiogram is within the normal range. Next, his cardiac function was preserved, but the functional study showed the abnormality finding. The treadmill test positive at the recovery phase, and perfusion defect was documented in Salim spec. Let's see the coronary angiogram next. Right coronary angiogram showed the intermediate diffuse stenosis at mid to distal RCA, and left coronary angiogram showed the tight in ISR at the circumflex ostium at proximal circumflex. And next, there is also noted there is a ISR in mid RAD.
Is it just a minimal narrowing and the 30%, 20%? Okay.
Yes. Next. This is
okay. So looking at exactly 1 year ago, and he underwent the two designed suck and the two designed medial RAD left main crossover. At the time we did the crush stenting. So and look back our 1 year ago final angio, you can see the done the complex coronary angioplasty. RAO coral view is well done, and this look like this spiral view is expanded well. Next one. Also shows the previous IVUS, and the proximal suck is well expanded, and the suck ostium is widely opened, and the crush result is very good. Okay, and could you show us today's coronary angio? This is the first view. Patient complained minimally related chest pain, Salim scan, treadmill was positive. Looking at the coronary angio, very tight stenos of suck ostium, also ISR extended to the distal the suck. And next one.
Next.
So this is the spiral view is very tight, nearly subtotal ISR region of the suck ostium. Next one. This is the epicranial view. You can see the 30% and the mild stenosis of mid RAD. Next one. So this is how much the compromised suck-ostium after put the wire. We select a French guiding caster and the Xeon black suck and the Xeon blue LED, and after even wiring passage flow was compromised. Next one. So initially we tried to the IBUS, but the IBUS does not pass. And next one. So this is IBUS, and we tried to 2 and 3 times. Is IBUS does not pass, and how much narrowing that means suck-ostium. So I give the comment to the Professor M.K. Hong and Shaoliang Chen, and we will have some discussion time at this moment.
Okay, this is very interesting cases. Why do we use the imaging in these cases? The reason is two. One is we have to evaluate the under expansion of the ostium of the circ. We have to verify, and the second one is what is the neo-intimal characteristics of the ostium of the circ. So in these cases, because of the region, instant restrictive region at the circ is too tight. You need a little bit dilation for the passage of the IBUS caster, and then do the IBUS, and then we will have a plan to what can we do, what is the real situation.
So that is exactly expect Professor M.K. Hong the expectation. We did some next one. We did just a 2.0 small balloon, and then we did IBUS evaluation, and we're gonna show the IBUS just after small balloon 2.0, and they thoroughly evaluated. And the next one, and then this is next one. This is 2.0, and then check it up the IBUS from the distal suck and the suck-ostium. Could you show us the IBUS? Okay, the prior stand is a 2.75 distal part. The distal edge is good. Yeah, okay, and this is the distal part of the suck. And here we can see that there is some neo-intimal hyperplasia and the low attenuation, the neo-intimal hyperplasia. And the prior 2.75 distal part, the suck-ostium is 3.0. The 1 year ago, we did the high pressure balloon distal part 2.75 non-compliant balloon, and the proximal part is 3.0 non-compliant balloon. Okay. Okay, could you slightly more speed up? And this is coming from the proximal part over here. Okay, you can start, and then we can see this is the proxy suck. And we already did some 2.0 small balloon to evaluate the status of neo-intimal hyperplasia. You can see some modification of the suck. Okay, and the suck-ostium is coming soon. This is suck. Okay, we can see the wire and the 6 o'clock. And the suck-ostium is very tight. And there is a neo-intimal hyperplasia. Also, we're going to check quickly from the proxy LAD to left main. Could you show us the proxy left main to proxy LAD to left main? Okay. 우리가 LAD에서 본 거 있죠? We also check the both branch and 쭉 앞에서만 쭉. Okay, start. 여기가 이제 썩 오기 전에. Okay, this is proxy LAD. LAD part of stand is 아니 서크 들어오는 데를 보여줘야지. LED part of the stand was there is nearly no neo-intimal hyperplasia, and you can see the suck coming from the 12 o'clock. Okay, and the LED part is there is no neo-intimal hyperplasia, so we evaluate the IBUS thoroughly. So I think we have discussion time at this moment. How we gonna treat and. Already 1 year ago and underwent a 4 drug-eluting stent. What is your recommendation? How do you thought is what is the optimal strategy to treat this diffuse ISR lesion?
How much minimal stent area for the circumflex ostium?
Circumflex ostium is the stent area, and could you measure the stent area?
Minimal stent area, yeah.
Yeah, it's around 2 millimeters square, I think.
This is subostium stent area. Okay. 좀 바깥쪽이잖아. 거기 스텐 에어리어를 재는 거잖아.
Stent area.
stent
I
area.
agree with the Dr. Wu's question. The key point of this patient is the actual stent size and the actual vessel size and the arterial circ is for me it is definitely the stent under expansion at the arcima of the circ.
There was a stent area is 7. Okay.
Not too bad.
So we already did some the minor inflations using 2.0 circle ostium is so. And how do you think about what is the good optimal strategy this patient just accept bypass surgery? How do you think? Any recommendation from
Panel?
I think we should use 3 or bigger cutting balloon first, and then use drug-coated balloon. And finally, I think we need a post-dilatation balloon to dilate from LAD to left main and keep the structure right.
That is good option. So, and looking at the current available data, Belarus study is the largest registry for ISR published. One is the European Heart Journal, one is published in the JACC. And on the basis of a Belarus registry done the Adnan Kastrati comparing the several modality repeat drug loading stent versus DEB versus the balloon angioplasty, current available data shows the additional drug loading stent is the most effective treatment, and DEB is the second, and the POBA is the third. And so I think, but the concern about the already underwent a very long stent is if you're gonna do additional stenting, there is some concern about the thrombotic risk about that. So we pre-specified our plan that we did small balloon, and then we're gonna do, and the circle part was already implanted 2.75 design. So I'm gonna do balloon angioplasty and then DEB. So first step to treat this ISR region is the plaque ISR levointimal hyperplasia modification is important. So I select this is a 2.75 cutting balloon. 오케이, 조금만 들어가보자. 이게 2.75죠? 네. 자, 우치. 딱딱하다, 그치? 잠깐만.
This is because the under expansion of osteosynthetase stem.
여기서 한번 살짝 가봐. 4, 5.
So it will be not easy to get cutting balloons through.
디플릿. 아니면 NC로 하고 다시 들어가도 되고. 자.
So, Dr. Park, is this a new generation cutting balloon or the older one?
No, this is a Boston conventional use the cutting balloon.
Not the Wolverine?
Yeah, not Wolverine.
Okay.
I feel it's the older generation.
4, 5. 노미널 얼마? 6. Okay, save. 디플릿. 잠깐만.
One of the questions regarding Shaoliang asking regarding your DK crush compared with this case maybe only a conventional crush. What do you think that the failure of circumflex osteo will be low compared with conventional crush? DK crush will be better. What do you think?
6. Okay, say.
Yeah, John, I think your question is great, but for this case, probably standing technique as a first PCI was a Q-lot. Is it? Dr. Park?
노미널이 6죠? 자, 6.
6.
디플릿.
Yet, do you know what the standing technique as a first PCI for this
다시
case?
한번 가봐. 4, 5.
It's only the crush technique.
5.
Okay.
6.
So yeah, basically, John, I feel the major limitation of classic crush is the kissing invitation quality, and also the high possibility of rewiring from the
6, 8.
6, 8.
from the distal cells. Understand that will be a major problem for the occurrence of incident stenosis.
10. 12.
But this is the second time of restenosis, right? So I think we should be very, very careful.
14.
Okay. Okay, deplete. So the Dr. Antonio Colombo he participates our complex PCI meeting every year, and sometimes he emphasizes high pressure cutting balloon inflation. Bursting pressure usually 6, and he sometimes do more than 20 ATM. Is it there any experience for high pressure cutting balloon implantation? 자, okay, Angel.
Yeah, for
We have some experience, that the new version of
그다음에 NC balloon
16 atmosphere high pressure.
3.0.
Especially you want to expand it that the previous 10 somewhat better.
Okay, and then we did the cutting balloon dilation using the 2.75. This is a non-compliant balloon 3.0, 15. I do NC balloon dilation. The final, our goal is to do DB for 가슴 조금 손 올리시면 안 돼요.
So, Dr. Park, my question is why first use cutting balloon, then NC balloon?
Yeah, so I think Shaoliang Chen, your comment is very nice. I think sometimes we can do the NC balloon first, sometimes do the another scoring balloon, something like that. But that is my experience. There is no absolute data about comparing just the NC balloon versus the cutting balloon versus. But on our center experience, if you're gonna do a cutting balloon, something like a more aggressive IS neo-intimal hyperplasia modification, we can do expanded well NC balloon, also expanded well more larger the stent area. Okay, this is the 3.0.
Yeah, they commented from Dr. Kefei but not me. But usually I prefer NC, cutting, and DCB.
조금만 들어올게. 자, go.
Actually, I agree with Dr. Park's opinion. If it is available, as we know, cutting balloon is quite bulky, so it's sometimes it's a difficulty to cross the lesion. But if it is possible and available, I prefer the cutting balloon first. It makes some crack within the neo-intimal, so the more convenient and then the easier to the more dilation and then the next procedure.
Yes.
This is 3.0 NC balloon, 14.
In the case of
16,
15,
18.
18.
오케이, 디플릿. 몰핀 2mm만 주세요. 터졌나? 안
터졌어.
안 터졌어?
Yes.
네, 자, 고. 10, 12, 14.
14.
But Sunao,
16.
we could not hear you very
Okay,
clearly.
자, 고. 14, 16.
16.
오케이. 오케이,
Can you
디플릿.
hear me?
오케이,
Yeah,
오케이,
now
I
we
can hear
can
you.
hear you.
Okay, so in the case of instant
Ten,
response,
12, 14,
we use
16.
just ballooning. Sometimes
18.
More and more.
in the case of
오케이.
cutting balloon,
20까지 갔죠?
Yes.
we can
16까지 갔습니다.
slipping. So better to use
여기서 한번 찍어보자. 라이트로 한번 줄까?
cutting balloon in that kind of case.
I expect that the angiographic appearance after the non-compliance balloon, distal part is the well expanded,
Okay.
but in the
자,
proximal
찍어보자.
part, angiographic appearance a little bit
풀샷.
undersized.
Yeah, I recommend to use 3.5.
충분히
3.5 or
Prox.
so.
Yeah, for proximal sir.
그치? 자, 그러면
예,
그거죠.
좀-
DB.
DB 2.75.
Yeah.
오케이.
And Chiung-Jen, I think Dr. Park is very busy. I have one question good for
예,
you.
그 뒤에
So
닦아봤는데.
after DCB for second flash, do you recommend to you to kissing balloon inflation from either AD sir?
So, and we previously put the 2.75 23, proximal part design 3.0 28. We required total cover of the sock stand. So we selected this is a 2.75 28 drug-eluting balloon. That is a Boston Scientific agent. Current available another company DB used the all is a paclitaxel coated balloon, but I know that some another country sirolimus coated balloon is available, but not available in Korea. And how about do you have any experience sirolimus eluting balloon for the treatment of ISL region?
We are just participating in sirolimus coating balloon in China. So far we have no more data. We are waiting for 1 year follow-up. Another point is that even drug coating balloon is is strongly recommended for incident restenosis, but there is very limited data for incident restenosis of the bifurcation study. So for this point, Jung-Ren, do you have any experience to share with us?
We did have some experience in the TCB publication, but one of the factors still anatomical, circumflex osteo, diabetes, uremic 3 critical factors that can influence after TCB treatment for ISR.
Time, nominal 6.
3 important factors.
Okay, we will wait at least 35 seconds. This is a 275 agent drug coated balloon.
We do not find it is particularly more effective than the other DB. In our limited experience, we found that they are more or less similar. I think the key of the DB is not the drug.
25 seconds.
The most important is the experience.
27, 28.
I mean, the drug, how it goes into the lesion.
3,
There are
4,
some,
5. Deplete.
for example, some use different material to make sure the drugs stick onto the part.
NC를 3.5 LED. And then we apply the 35 seconds for distal circulation.
How will you do the DB for the oxygen shirt? Will you do DB kissing? I mean, maybe put one more DB on the AAD, and then we do a kissing.
이거는 NC balloon.
1 DB on shirt, 1 DB on AAD, and then do a kissing DB.
So
because we may damage the AAD also.
Yeah, right. So that was a very important question. Sometimes concerned, but this patient LAD is absolutely no neointimal hyperplasia. So finally, and this is I put the NC balloon 3.5. 15 for LAD, and then I'm gonna apply the additional DB for SOC, and then after the final DB for SOC, and then pull back the both branch, and then final kissing, and then I'm gonna finish. Yes.
So, Dr. Park, will you use the NC in RAD and the DCB in Sunflash to do kiss?
Yeah, right, exact. Yeah, NC. So, and the Dr. Horam, the suggestion, and we can use the LAD, the DB, and the SOC DB and final kissing, but LAD is okay, patient. Okay, this is the additional DB 3.0. Okay, got it.
So, Dr. Hong, do you have any experience about the post-dilation of the DCB?
That's it. 됐다. LED 좀 더. 지금 LED 내려놔. 지금 하는 거 아니야.
Personally, I think as
이 정도 충분히 나와서 할게.
I will do the kissing balloon after the DB at the soul. But I think as still size of the DB is not so
We will wait 35 seconds. Okay, this is a 3.0 Boston Scientific agent and drug paclitaxel coated balloon. Okay, 20 seconds. We should.
Sometimes when you inflation from the left main to the circumflex, you might blockage that the flow
가슴
also
조금
from
아프실
left main to
거예요.
everything.
27,
So if the patient every
28,
dysfunction,
30,
maybe you cannot tolerate
1,
long
2,
time inflation.
3, 4, 5. Okay, deplete.
Yeah.
Okay.
Usually, for DCB in left main, usually we inflate 15 seconds, and then stop. So repeat 15 seconds inflation.
정강 선생님 옆에서 좀 도와줘야
At
돼요.
this point, after DCB for sir, Kefei, do you have any experience to use another NC balloon insert to do kiss?
간다. 자, 고.
Actually,
같이 가야지. 6.
I will not do that.
보면서 적어 보면서 가야지.
I will consider if you use another NC balloon in circumflex, that will impact the effect of this.
디플릿. 한 번만 더 하자. One more time. Okay. 자, 저거 보면서 자, 고.
After the kissing, do you consider to do pop in this sort of situation?
10. Okay. 1, 2, 3. Okay. So we did everything, and then we're gonna check the final angio as well as IVUS. Okay, got it. 잠깐만.
Perfect.
잠깐만. Okay, nitro. So, and we just available paclitaxel coated balloon, and so we don't have not much option. So I think if sirolimus would be available, we will have another choice. Okay, 자, 테스트. 한번 다시 잡아. 테스트. 오케이, 엔지오 레디? 찍어볼게. 자, 갑니다.
Fine, angel.
풀샷. Okay, good. I think the result.
What is your expected the lumen area at the asymptom of the circ after the kissing balloon?
Yeah, so
no IVC evaluation.
Yeah, before IVC evaluation, I guess more than 7 at least. Okay.
Okay.
이게 서크지?
Let's see. It's greater than the 7 or not.
Okay.
If the lumen area is less than a 7,
1번 봐. Okay, I'm gonna
what can
show.
you do?
Okay, I'm gonna shortly showing the circle ostium first and the limited live time, and then the room number 1 ask showing the final result.
Okay.
Briefly showing the circle ostium first, and then move to the room number 1. Okay, here. Okay, go. Stop. This is 더 들어가야지.
One more.
Okay.
More
Okay,
advanced.
got it. Okay.
Okay.
자, start. Go.
Good.
This is the suck.
This is a proximal circ.
Yes.
So Dr. Hong, so question goes for you. So if I was to confirm the minimal stent area and the osteocer less than 7 millimeters, how do you do?
Okay, this is I think well expanded. Okay, we did. Okay, so this is
Okay.
suck ostium. Could you measure suck ostium?
Asymptom of circ.
야, 그래 뒤에서 이제 들어가서 뒤에서 쭉 한번 봐야 되니까 한번 재보세요.
No. Just this cell. Okay.
Okay, here. 잘 재봐.
I think it's less than 7.
좀 안쪽으로 돌아야지.
Only
Yeah,
5.3.
5.7. Not match my guess.
Yeah.
What about the additional PCI with a 3.5 with a non-compliance balloon at the asymptom of circ?
Yeah, so and initially we put the 3.0 the stand on the basis of the IVC evaluation. So and I still just the 3.0 would be okay. And the initial time 1 year ago on the basis of IVC, and we select 3.0 rather than 3.5. So I think we did a lot of things. Even the NC balloon 3.5, we performed more than 20 ATM. So even though we're gonna do 3.5, I think the current result would be okay. Yes.
If you worry about the population of the coronary vessel,
I'm
why don't you try the 3.5 non-compliant balloon, which was used in the LAD? Why don't you try a little bit dilate?
Next time I'll try to do that.
Okay, excellent job.
Okay, thank you.
Thank you.
뒤에서부터 한번 쭉 보자. 여기서
넘어왔습니다.
뒤에.
Okay.
Turn.
Okay.
Okay.
Dr. Ba, please
All right.
show us your result.
All right, great. This is, we have limited time. This is almost the final angel. Actually, we stand close to 48 millimeters. I have a confidence. 48 is not too much different. All right, this is based on the Dr. Hong's data. Anyway, this is high pressure with 3.75 and up to
4.1.
4.1, 4.0.
4.0.
All right, millimeter. It's big balloon inflation, a crossover, part technique, and we're going to show in the later obvious findings. Yes. However, just issue is look at this OCR part of circumflex. All right.
Good.
After high pressure inflation, the degree of stenosis more than 80-85%. So what would you do there?
Can you please show the angio?
Shaoliang Chen.
Yeah.
All right. Just based on the angio finding.
Yeah, angiography looks very, very great. I think you know any other reason to touch a single flash?
All right. What about Dr. Lam? Dr. Nakamura. What if you were the operator, you want to do the kissing balloon inflation or some balloon inflation for that?
No, I will do not do.
Definitely not.
All right, great.
I think the result was perfect already, and we will, for example, we can follow up the patient. If the patient complain of angina, then we further restudy something.
Right. I really, I am, to be honest, happy. We've changed a lot conceptually. I am, very old guy. So from the last 10 years to 15 years, fancy, smart interventionist to, how much, complex reasons of kissing bone inflammation. Right. Absolutely. We've changed it a lot. And so finally, we're going to show the FFR, right?
Yeah, we check the FFR. Yeah. We check the FFR on the circumflex, and this is the result.
All right, hyperemic status.
Yes,
right?
in hyperemic
we
status.
used more than 200 microgram adenosine per minute, and the maximum hyperemic status. The circumflex ostium is 0.84 FFR.
Negative.
And this is final angio, right? After remove the wire, the degree of stenosis reduced. It's around 50%, right? After the remove the wire, we fix up that, and so we finalize these cases.
Excellent validation of the severity of the circle with the pressure wire. Excellent.
All right.
Excellent. Congratulations.
All right, thank you. Thank you again.
Congratulations.
Thank you for joining us. Sooner or later, we're gonna meet face to face.
Hopefully.
Delicious dinner too. Okay, good. Good to see you.
Good to see you.
All right.
We're gonna show us the final IVs from the LAD and left main. Could you show us? This is Fox LAD. Okay, suck ostium is coming, and the crush part is good, and the suck ostium is widely opened, and I think fully expanded the distal part and the proximal suck, and that was the crushed part. Okay, we're gonna check the final angio. Okay, push out. Okay, good. And then spiral view. Okay, test. Okay, angio. 자, push. 굿. 약간 안 가리게 요것만 조금만 더.
Excellent job.
자, 테스트.
좋습니다.
Okay, push-up. Good. So I think this case is a very representative case. How can we treat the left main ISR region? And this patient already underwent a lot of drug-eluting stent. At this time, we did a drug corridor balloon, and then we do sequential some plug modification using cutting balloon first, and then non-compliant high pressure balloon dilation, and then drug-coated balloon is the total part of the suck, and then final kissing, left main part non-compliant balloon, and the DB final kissing, and this is the final result and previous one. So I think that was our expected the goal of the successful procedure. So any comment or question from the moderator or panel?
Yeah, congratulations to your excellent results for such a challenging incident restenosis. But the patient had 2 times of incident restenosis. So I think all our concern is about the coming of next incident restenosis.
Yeah, right.
So let's open our eyes. Is it possible? So Dr. Park, can you email us after 6 months about this patient? Okay.
Yeah, okay, great.
Thank
so
you.
1 year later, I will check the follow-up angio. Okay, thank you.
Thank you.
Thank you, wonderful.
Thank you.
Well, thank you. See you next time.
Thank you everyone, and joining our TCTAP virtual meeting, and I hope to see everyone in the in-person meeting next year after successful vaccination. Appreciate. Thank you.
Okay, thank you.
Thank you. Bye-bye.
Bye-bye.
Chen.
Okay, our friends, thank you so much. In last 1 hour, we share the 2 very excellent cases, distal left main disease, from Asan medical teams. So 2 Dr. Parkers showed that they are excellent technique, individualized strategy for different kinds of distal left main lesion. I think to the final results, were very, very wonderful. So from these two cases, we have learned much more from other medical teams, yearly experience. So here, I also thank you, Dr. Chiung-Jen, Kefei, Do-Yoon, Gogas, Dr. Shaoliang, my good friends, Dr. Sunao Nakamura, and my good friend, Dr. Hong. So hopefully can see all of you in Nanjing in the near future. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.